Hi everyone, I hope you can hear me and see me okay. It's 6:30, so I think we'll make a start. So I'd like to start off by welcoming everyone to the penultimate webinar of our regional series run by the National Surgical Teaching Society. And I'd just like to thank you all for coming here today this evening. I'm going to start off by introducing Dr. Tara Dogra. So Tara graduated from the University of Bristol and completed her BSc in Medical Management at Imperial College London, having completed a research internship at one of the top 10 radiology residency programs at the United States. Tara has now started training at the Oxford School of Radiology at the John Radcliffe Hospital. She really is an amazing teacher and has some really interesting questions lined up at the end. Without further ado, I'd like to hand it over to Tara.
Thank you very much. Hi, everyone, and welcome to today's talk on imaging and surgery. I'd just like to say a big thank you to the National Surgical Teaching Society for inviting me to speak this evening. Thank you very much for the introduction. So that's me. I'm Tara, one of the radiology registrars in Oxford. As you've already kindly introduced me, I did my medical degree at Bristol, intercalated at Imperial, made a quick pit stop in New York, and then came back to the UK for training. I'm now ST1 radiology registrar, and I'm currently working at John Radcliffe. So today, what I was really thinking was talking to you about imaging in surgery. We're going to run through a lot of cases which are primarily trauma and orthopedics based and general surgery focused. I'm going to give you some systematic approaches to help you review images independently, and this will help you both in your exams, in vivas, and whilst on the ward as a junior doctor. Hopefully at the end, we'll have time for some questions, and you're more than welcome to ask me about application processes to both core surgical training and radiology. So primarily within radiology, there are four main imaging modalities that you come across: X-ray, CT, MRI, and ultrasound. X-ray is very good for looking at bony injuries and assessing fractures. CT is also very good at a combination of assessing bones and soft tissues. It's also commonly used for preoperative planning, for example, in orthopedic cases, to see the extent of the fracture. We've got MRI, which allows us to look at non-bony structures, for example, soft tissue lesions in more detail, and ultrasound, which allows for more dynamic imaging. It provides images in real time and allows you to look at some internal organs whilst being able to assess blood flow. So to start with, I'm going to cover with some trauma and orthopedics cases. But before we begin, I want to run you through a structured approach on how you yourself can review some of the MSK films independently. So the approach to reviewing MSK imaging is going to be remembered with the acronym ABCS. So this is looking at your alignment and joint space, your bony texture, reviewing the cortex of the bone, and lastly, looking at soft tissue. But before you begin, it's really important to remember these general points. I'd highly recommend doing some ID checks on the patient just to confirm the patient's date of birth, name, and hospital number. Make sure you've got the right imaging for the right patient. It's also a good idea to review previous imaging. We're in a great time and space where we've got access to PACS, so you can see previous imaging that patients have had before and compare to see if there have been any changes. An example of this would be a patient presenting with osteoarthritis. If they previously had an X-ray, you can assess to see has there been any progression to the bony changes. Another thing that's really important in radiology is getting multiple views. It's not sufficient to have one view per joint. You need to have multiple views in order to ensure you've seen the entirety of the joint and you have a good idea of what the pathology is. And my fourth top tip for you is to remember that there can be multiple pathologies. It's really easy to get blinded by the fact that you've spotted an obvious fracture, but to ignore a soft tissue lesion in the periphery of the film. So hopefully with me giving you this systematic approach to reviewing the plain films, you won't miss any pathologies. I'm sure many of you have seen this picture everywhere, but this is just to highlight the importance of making sure you've got two views because not everything is as it seems. So let's start with the acronym then. So A is for alignment and joint space. And essentially what you're looking at is a change in the alignment of bones. Change in the alignment can be representative of a fracture, subluxation, or dislocation. Since this talk is focused on imaging, I'm going to try and show you as many images as possible of common cases that you're likely to see. Hopefully these will be easy to remember, and it will look super impressive if you can remember these on a medical surgical ward round or in theatre. One thing that I would say is you need to remember which side the pathology is on. This is particularly important for pre-operative planning. Usually the X-ray is labelled, so as we can see here, this is an X-ray of a left shoulder. But if not, make sure you establish which side you're looking at before you go to your seniors. And also correlate this clinically, i.e. make sure that the correct side has been imaged by reviewing the patient. So if the patient is presenting with left shoulder pain, do make sure it's the left shoulder that's imaged. The trick to reviewing plain films, I think, is definitely orienting yourself to the anatomy. So just looking at this plain film here we've got the humeral head, we've got the glenoid fossa, here is the acromion, and here is the clavicle. So the clavicle has a medial end, it has a lateral end, and the middle point. And when looking at shoulder X-rays or assessing the clavicle, you also want to look at the glenohumeral joint. So your humeral head and your glenoid fossa should be nicely aligned. And if they are, we describe the joint as being end-located. And this means that the bones are in the correct place. Here on this plain film, if you notice, the head of the humerus is inferiorly subluxed against the glenoid. And this is what we call subluxation. This means that there's a gap between the inferior cortex of the acromion and the humeral head. Now, this is a very, very common finding. I have no doubt that almost all of you will come across this either in an exam setting or in your training, and it can represent a multitude of pathologies. Typically, this is seen if a patient's had a fall or developed a fracture and subsequently developed a joint effusion. And the effusion fluid, whether it be blood or not, has caused the joint space to increase and therefore led to inferior subluxation of the humeral head against the glenoid. So again, here, I'm not sure how well it projects on your screen, but we're looking at an example of joint dislocation. So this is a plain radiograph with 3 different views of the right hand. And if you look at the 5th digit, there is joint dislocation of the metacarpophalangeal joint of the 5th digit. And again, it highlights the importance of why multiple views are required. It's much more emphasized on the oblique projection rather than the lateral. So continuing with our acronym, as part of alignment, we also need to assess the joint space. It's really important to carefully look at the joint space and identify changes such as joint space narrowing. Now, this can be due to cartilage loss, cartilage calcification, for example, with chondrocalcinosis, or new bone formation with osteophytes. Subchondral sclerosis, which is increased bone density, can also be present along joint lines in patients with osteoarthritis. And you guys may have come across this when you were revising for finals, or if you're still revising for finals, and it's the LOSS acronym to review osteoarthritis changes on a plain film. So this is a particularly nice example. This is a plain radiograph of a patient's knees. And as you can see here, there's osteophyte formation at the tibial plateau, at both the medial and lateral aspects. And you've got some joint space narrowing here at the medial tibiofemoral compartment and increased subchondral bone density, which is shown by this whiter appearance. So this is a classic appearance of osteoarthritic changes on an X-ray. So going back to our acronym, we've reviewed the alignment and joint space. Now we move on to looking at the bone texture. So if you remember, in the earlier stages of medical school, you'll remember that trabeculae are the fine white lines within the substance of the bone. So essentially, when you're looking at the bone texture, you really need to review any alterations to the density or disruption to the trabeculae, which could suggest a pathology. And an example of this here on this plain film, this is an ankle joint. So just for orientation, this is the left ankle. You can see here, you've got the tibia, and here is the fibula. And at the inferior margin of this plain film, you can see some of the bones of the foot. This image on the left of the screen is showing a very healthy trabecular pattern and a healthy cortex, which is in contrast to the image on the right. And this is a typical radiograph of osteomyelitis. And there are 3 key features I want to point out to you here. So we've got a total loss of that trabecular bony architecture, which we can see here. It's completely obliterated here. And we've got examples of regional osteopenia, which is exactly what you think it is, where there's a darker area here and here, where there's been osteopenic changes. And we've also got periosteal reaction, which is represented by this fuzzy appearance of the cortex of the bone. Periosteal reaction is actually the formation of new bone in response to injury or another stimulus of the periosteum surrounding the bone. It's really important to realize that that may be the only sign visible to denote a problem with the bone. For example, if there was mild osteomyelitis or a healing fracture. Once you're happy with the bony trabecula, you then need to look at the cortex, trace the outline of each step of each bone, as any step in the cortex may actually indicate a fracture or another pathology. This is particularly important in pediatrics because a slight change in the step may indicate a pathology that you may otherwise have disregarded in adult film. We'll come and look at some examples later, but peds changes on plain films are very, very subtle when it comes to fractures. So here's an example of where it's really important to trace around the cortex. So this is a plain radiograph of a left hand. And as you can see, we're able to see the metacarpals. If you trace around the metacarpals, you're expecting a nice, smooth cortex. And that's the case for the first four. However, where the red line is, and you're tracing around the cortex for the fifth metacarpal, you can see there's a step. And if you follow that step, you can see a black lucent line, which is obviously suggestive of a fracture. We've looked at the alignment and the joint space. We've looked at the bony trabeculae, and we've also looked at the cortex. So last but not least, we need to look at the soft tissue. You're looking for things like swelling, foreign bodies, and joint effusions. Whilst X-ray isn't the primary modality to assess soft tissues, sometimes soft tissue injuries can actually be very easy to visualize and can prompt closer inspection for bony pathology. So this is a really nice example and can also show you how you can use other factors in the plain film to help guide you as to where the fracture is. So this is what we call a characteristic appearance of something called lipohemarthrosis. Now, this is when fat and blood from the bone marrow escape into the joint to form this characteristic layered appearance. Fat is obviously less dense, so will float, and blood will sink to the bottom. Lipohemarthrosis is a characteristic feature of an intra-articular fracture of the knee. So if you didn't already notice by the big giveaway from this black arrow, the tibial plateau is gone in this patient, and this patient's had a fracture. Here's another example of how you can use other features other than the bone to guide you. So here we're looking at an elbow joint, and in any normal elbow joint, you're expected to have anterior and posterior fat pads. And these are shown by the dotted black line and the yellow arrow. Ideally, the fat pads should be closely adhered to the distal end of the humerus. But if they are raised, as is the case here with the anterior fat pad, it's a triangular shape. This is called the anterior sale sign. Anterior sale sign is indicative of an intra-articular fracture at the elbow joint. So similarly to how lipohemarthrosis is indicative of an intra-articular fracture of the knee, we've got an anterior sale sign here, which shows that there's a fracture at the elbow joint. Now, what exactly is fractured is typically patient dependent. So it's largely adults that we see a radial head fracture in, and in children, we typically see supracondylar fractures if we've got this appearance of the anterior sale sign. It's also important to note that you may not actually see a fracture line, and the only clue may be that the fat pads are raised. And if that's the case, this is known as an occult fracture. So what you would need to do in that situation is discuss this with your senior registrar or consultant, and the patient may warrant further imaging depending on the clinical picture. So we've seen examples of soft tissue swelling and joint effusions. The other part of the S section of our acronym is looking at foreign body. So very common cases you'll see as a junior doctor will be requests for imaging saying the patients have dog bite, query foreign body, query bony injury. And foreign bodies are typically radiopaque, so they're very easy to spot on imaging. But what you're actually looking for is where exactly is the foreign body? Does it go through the bone? Is it intra-articular and goes through the joint? Or is it causing extensive soft tissue damage? Sometimes on the X-ray, the radiographers are very helpful and may place an arrow to indicate where the area of concern is. So for example, the middle finger of the right hand. But it's really important to not disregard the rest of the film. You may notice a bony injury elsewhere. You may notice further foreign bodies. or there may be an incidental finding that you would need to notify the clinical team about. So again, having multiple views allows you to fully appreciate how far the foreign body extends. So we've gone through the ABCS approach on how to review appendicular films. So once again, it's alignment and joint space, bony texture, the cortex, and review of soft tissues. We're now going to go through some cases. Obviously, there isn't enough time to go through all of the joints, but I thought I would cover the main ones that you should expect to see as a junior doctor, either on the wards or on call. So we'll start with the clavicle. So ideally, to understand the pathologies on the X-ray, you really need to orient yourself to the anatomy. So this is an AP radiograph of the right shoulder. So again, you can see the humeral head here, the acromion, the clavicle, and here's the glenoid. So I tend to look at humeral head, acromion, and glenoid, and that tells me that the glenohumeral joint is end located. You're also able to trace the scapula through the lung field. So you can see the lateral border, the inferior aspect, and the medial border of the scapula. Another thing that's really important is if you're assessing for clavicular fracture, you need to be able to see the clavicle in its entirety. So this image is inadequate because we're not able to see the medial end of the clavicle, i.e. the sternoclavicular joint. So do make sure that before you're commenting on whether there's a fracture or not, you're able to view the image in its entirety. Injury to the acromioclavicular joint, including a fracture of a clavicle, is very, very common. So the acromioclavicular joint, as you saw on the previous radiograph, is basically the joint between the acromion of the shoulder with the lateral end of the clavicle. And this joint is typically assessed using the AP view of the shoulder. Some trusts may offer a specific clavicle projection only. And how you assess if there's an injury is you measure the width of the joint. So you're measuring the gap between the acromion and the lateral end of the clavicle. In the context of trauma, a width of 8 millimeters or more should be viewed with increasing clinical suspicion. And as you guys make that transition into hospital, those of you that haven't done so already, you'll be very familiar with the PAC system, and there is a very handy measuring tool which will allow you to measure that 8 millimeter gap. The caveat to this, though, is that the joint space in the acromioclavicular joint is very variable between patients, so it's often not able to be used accurately in order to make a decision. Another way in which you can determine whether the acromioclavicular joint is intact or not is drawing a line. So if you draw a line at the inferior cortex of your acromion and extend that all the way across the clavicle, that should align in order to show congruence of the joint. And if it doesn't align, as shown here, that's indicative of some subluxation. So subluxation is detected as a step between the inferior cortices of the acromion process and the clavicle, as shown in this diagram. The third factor to think about is that actually sometimes the radiographic evidence itself may be inconclusive. So in those patients, what you really need is an AP radiograph of both shoulders. And these patients will need to hold a weight in each hand. And with direct comparison of your injured and uninjured shoulder, you're basically able to either rule out or reveal a discrepancy. The theory being that if they're holding a weight, it should exaggerate any discrepancy in the acromioclavicular joint. So moving on now, we've covered the clavicle. I'm now going to talk to you about forearm and distal radius fractures. So this is a zoomed out X-ray of the forearm. We've got a general appreciation for the bones here. We can see the radius, the ulna, appreciate some of the carpal bones and the elbow joint. But realistically, if you want to image the distal radius, this is the type of radiograph you need. Fractures of the distal radius are a very common presentation to A&E. And the common history you'd expect to hear is an elderly patient falling out on an outstretched hand, and that's given in the acronym FOOSH. So if you see FOOSH in the clinical notes, that's what it means. Again, super common presentation and definitely something you want to be familiar with in terms of recognizing on images. So those of you that have sat exams and those of you that are yet to sit them, you'll know that this is a Colles fracture. Now, personally, I really hate these names. They're called eponymous names. I think fractured distal radius with a description is much more helpful. As you know, there's also something called a reverse Colles fracture or a Smith's fracture. And I think you run into the risk that you can often get the two types confused as to which fracture means what on the X-ray. But if you actually just concentrate on accurately describing the anatomy, neither you yourself nor the person you're explaining the findings to can get confused with what X-ray shows what. Distal radius fractures are one of the most common injuries of the wrist. So if we follow our systematic approach from earlier and we look at the alignment, we can see that this is completely lost on the lateral view. If we look at the bone texture, we can see that there's significant disruption to the bony trabeculae of the distal radius. And lastly, on assessment of the cortex, we can see that the cortex is not intact at all. With regards to soft tissue, it's quite difficult to assess here, but obviously the more extensive your injury is, the more extensive you expect the soft tissue swelling to be. As part of S in our ABCS acronym from earlier, we should also note that there is in fact a radio-opaque foreign body, and it's the patient's ring that's seen on the fourth finger of the left hand. Whilst that's not relevant to the pathology, it's good for you to get into the practice of looking at every aspect of the film to make sure that nothing is missed. And it just shows that you've acknowledged it and you're aware that it's there. So if we're describing the fracture now, we need to comment on whether it's intra-articular or not in the first place. So i.e., does this fracture extend into the joint space? And this is of particular importance to the surgeons as they make decisions on whether to operate or not and what operation to do based on an intra-articular fracture. So if you trace the lucent line of the fracture, you can very much see that it extends into the joint space. So this is what we would describe as an intra-articular fracture. Then it's quite helpful to comment on the number of fracture fragments. So whether if there are only 2 fracture fragments or if they're multiple. If there are multiple fracture fragments, we refer to that as a comminuted fracture. And in this case, you can see that the distal radius is completely gone. So that's definitely a comminuted fracture. Following this, you need to make a comment on angulation. So angulation refers to the way in which the fracture fragments are angled. And when referring to this, you always comment on the distal fracture fragment. So you describe the angulation of that in relation to the rest of the bones. So angulation in this case can either be dorsal or volar. I sort of remember it that volar sounds like palmar, i.e. pointing towards the palm, and therefore dorsal is the opposite. So if you look here, you can see that there's dorsal angulation of the distal fracture fragment, which is that characteristic dinner fork deformity that you always hear about with these type of fractures. So overall, to conclude for this radiograph, if you were describing this fracture, you would say that there is an intra-articular comminuted fracture of the left distal radius with dorsal angulation of the distal fragment. So I think if you said that to your registrar or your consultant, they'll know exactly what you're talking about without having actually seen the image themselves. So just for completion now, it's obviously useful to appreciate volar angulation. And whilst I hate eponymous names, this is what some of you may know of as a Smith's fracture or reverse Colles fracture. You can see that there's volar angulation this time of the distal fracture fragment, and that's better appreciated on the lateral view. And in this radiograph, you can see that actually both bones are fractured, both the radius and the ulna. So the final pathology I want to touch on in the wrist is scaphoid fractures. So the scaphoid bone is one of the carpal bones. Top tip for all of you starting on a surgical job, please make sure you know the carpal bones. When you go into surgical handover meetings or trauma and orthopedics meetings, everyone assumes that because you're fresh out of med school, you'll know all the carpal bones. So please revise that and don't put yourself in an embarrassing situation like I did. If there's a fracture of the scaphoid, you can divide it into different areas. Either it can be the upper pole, the lower pole, or the waist of the scaphoid. Fractures of the waist of the scaphoid are most common. And that's what's shown in this diagram here with a red arrow. So any fractures in the waist of the scaphoid will jeopardize blood supply of the proximal fragment. So if the patient is managed incorrectly, they run into the risk of non-union, delayed union, or more severely, avascular necrosis of the proximal fragment. So definitely not one to miss. A clinical point to also note is that sometimes scaphoid fractures can't actually be seen on imaging until 5 to 10 days after the injury. So it's really important that these patients are followed up afterwards, because at this point, resorption of the bone has occurred around the fracture site, therefore making it more obvious. And I touched on it earlier, but I wanted to show you an example of a fracture in a pediatric patient. So distal radius fractures are not only seen in the elderly patients, they can also be seen in pediatric patients. And here is what we would describe as a buccal or a torus fracture that's seen in children. So if you can see, it's very subtle where there's a defect in the cortex, not at all like how it appears in adults, completely subtle defect here. So again, just something for you to be aware of when you're tracing the cortex. Really get your eye in and be certain that there's no defect in the cortex. And this asterisk is here because there's actually a fracture of the ulna as well. So for our final joint that we're going to cover in the trauma and orthopedic section, we're going to cover the hip. So hip fractures are particularly prevalent in the winter season. As you already know, they're associated with high morbidity and mortality. And neck or femur fractures will definitely be the bread and butter of any Jerry's placement you do or surgical rotation. So it's better to get your eye in now to know what you're looking for. Naturally, they're more likely to be seen in older patients who have increasing unsteadiness of gait and reduced bone mineral density. So they're commonly seen in osteoporotic women. And it's in this category of patients really where neck or femur fractures can be sustained on very low impact injuries, so have a very low threshold for suspecting a neck or femur fracture in an elderly patient. This is in contrast to younger patients who can still sustain neck or femur fractures, but it's more likely to be a high impact injury, for example, a road traffic accident or other major trauma. So in order to adequately image the hip, you're expecting 2 projections. You basically need an AP of the whole pelvis to include both hip joints, and you need a lateral projection of the painful hip. So this is an AP projection of the pelvis. Note that in this projection, you're able to visualize both hip joints, as well as the sacroiliac joints and the pubic symphysis. And this is a technique that's used to obtain a lateral view of the left femoral neck. So I sometimes find it really helpful to understand how the image was taken in order for me to figure out what on earth I'm looking at when it comes to looking at the X-ray. So in this case, the painful hip was the left hip. So it's the right leg that's lifted up and out of the way, so the X-ray beam can be shone onto the left hip and then result in your lateral projection. And with a bit of magic, this is what it looks like. So that's what you're expecting your radiograph to look like. It's a lateral projection of the left femoral neck. And you can see the schematic representation has highlighted the femoral neck region in red in the diagram on the screen. So going back to our original system then for analysing the plain films, back to our acronym, ABCS, what you're looking for in a hip X-ray is you really want to see a smooth, intact cortex with no buckle, no step, no ridge, and a nice and normal trabecular pattern. You do not want to see any transverse areas of sclerosis. The intertrochanteric region, i.e. between your greater and lesser trochanter of your femur, you do not want to see a black or lucent line transversing that because it could be indicative of a fracture. And you don't want any interruption to the cortical margin either. Once you're satisfied that there's a fracture, you then need to be able to correctly describe where it is. I personally find these simple schematic representations very helpful in classifying hip fractures. Essentially, what you need to do is be able to identify, is the fracture intracapsular or extracapsular, as that's what's ultimately going to affect management for the patient. Intracapsular fractures tend to go from the femoral head to the base of the femoral neck, and they can be subclassified as subcapital, mid-cervical, or basicervical. And extracapsular fractures are anything that's inferior to this from the femoral neck downwards. So this could be intertrochanteric, for example, between your greater and lesser trochanter, or subtrochanteric, which, as the name suggests, is anything below the trochanters. Again, reviewing imaging is all about being as concise and specific as you can. So when you're the junior doctor on call, calling your surgical registrar or consultant, you're able to describe what you see. I just want to reiterate that your main aim is that they should be able to know exactly what kind of fracture you're looking at and without having to view the image directly. So back to the radiographs now, and back to our acronym. So as part of alignment, there are a number of lines which we can look at on both pelvic x-rays and hip x-rays to help guide you when you're reviewing the plain film. Since this is specifically focused on hip x-ray, I'm going to concentrate on one particular line, and that's called Shenton's line, which is marked in green on the radiograph. So again, just looking at the anatomy, you've got your acetabulum and your femoral head sits nicely in there. Your femoral neck is where you're looking at for any possible fractures. You've got your greater and lesser trochanter, and your superior and inferior pubic rami, both of which can also be fractured. Shenton's line itself goes from the inferior cortex of the superior pubic ramus all the way through to the medial aspect of the femoral neck. And it's any disruption to Shenton's line which makes you more suspicious of a fractured neck of femur. So if on first glance you feel like you can't see a fracture, it's very useful to utilize Shenton's line to make sure that there's definitely no fracture. So we've touched on how to review hip x-ray. I'm going to just cover now some major pitfalls when reviewing them. So firstly, acetabular fractures. So these can actually be accompanied by very similar clinical features as a neck of femur fracture, and therefore require much more careful review of the radiograph because they can easily be missed. And an example of that here. So this is an AP radiograph of the pelvis, and as shown with the red arrow, we have an acetabular fracture. I think with pelvic x-rays, what's really helpful is to utilize the rings. So if you trace the outline of the ring, you really want super smooth edges. Any pointed or jagged lines would definitely alert you to the possibility of a pathology, which in this case is an acetabular fracture. Then we have pubic rami fractures. So a fracture of the pubic ramus can actually present with symptoms identical to that of a femoral neck. So in fact, a fracture of the superior pubic ramus is one of the most common fractures in elderly patients. So if you look at this radiograph, you can see fractures of both the superior and inferior pubic rami. As you may already know, the pelvis is a ring structure. So typically that means if it breaks in one place, it breaks in another. So if you imagine a polo, it's really difficult to crack a polo in one place. And for this reason, it means if you've seen one fracture, definitely keep your eyes peeled for another. And lastly, looking for a ring of osteophytes around the acetabular margin. So this is a very focused radiograph looking at the left hip joint, and there's very severe degenerative change noted at the hip. You've got a ring of osteophytes that can be seen around the margin of the acetabulum, and that's producing this sclerotic appearance around the femoral neck. And if you haven't seen that before, it can basically mimic a subcapital fracture. So those are just some pitfalls for you to be aware of. We've covered the trauma and orthopedic section now. I'm just going to move on to some general surgery cases. Once again, all of these cases are very common, very general, and you can expect to see them on any medical, surgical, or A&E shift. So just like with our MSK films, with abdominal x-rays, there's also a systematic approach, and this time it's BBC is our acronym. So bowels and other organs, this includes small bowel, large bowel, kidneys, liver, spleen, etc. Then you look at the bones. So actually abdominal x-rays cover quite a large area, so you're able to get a good image of ribs, lumbar vertebrae, sacrum, coccyx, and the proximal femur. And lastly, calcification or any other artifacts, for example, renal stones. Again, the same general points apply as they did with MSK films. Make sure you've got the correct patient, make sure you have adequate imaging, and make sure you've reviewed any previous scans they have. Particularly with abdos, you're looking at any previous CTs that also may have been done. I think what's really important is when you're requesting and reviewing imaging, you really need to think about what it is that you're imaging. So in abdominal x-rays, you're essentially visualizing everything from the diaphragm to the pelvis. And you really need to ensure that the exposure is adequate in order to gain an appreciation for both the large and small bowel. And again, something to think about is whether you need an AP supine or AP erect view, depending on what pathology you're trying to rule out. So for example, if a bowel perforation is being investigated for, whilst you may go for an abdominal film, you do actually need an erect chest X-ray in order to correctly identify the pathology. So let's start by looking at the first B. So this is bowel and other organs. So this table, I'm sure lots of you would have seen before when you're revising for finals. It's just to summarize the differences between large and small bowel and how they appear on abdominal X-ray. So again, you're looking at the differences between your valvulae conniventes seen in the small bowel and the haustra of the large bowel. By and large, the small bowel you're expecting to lie centrally and the large bowel peripherally. So this is an abdominal X-ray showing both large and small bowel. The white arrows show large bowel, which is around the periphery, and the black arrows show small bowel, which is in the center. This is a nice normal abdominal X-ray with no pathology. Another X-ray for you, small bowel mucosal folds are called valvulae conniventes, which cross the full width of the bowel. And large bowel haustra shown here with the white arrows. When you're reviewing the bowel, it's really important to think about bowel diameter. So upper limits for the normal diameter of different parts of the bowel vary, and they can be remembered with the 369 rule. So that's 3 centimeters for the small bowel, 6 centimeters for the colon, and 9 centimeters for the cecum. We're now going to have a quick look at small bowel obstruction. So again, hopefully this is familiar to most of you. Common causes of small bowel obstruction, the main one being adhesions, represents a good 75% of causes. Abdominal hernias, or any intrinsic or extrinsic compression by neoplastic masses. So here, if you look at this abdominal X-ray, this is an example of small bowel obstruction. You've got clear dilatation of your small bowel, more than 3 centimeters, which is your giveaway of SBO. And if you note, there's a more prominent appearance of your valvulae conniventes, and that's what we refer to as a coiled spring appearance. So again, if you're the junior doctor on call, whilst you're not expected to report these independently at all, it's a really good habit to get into. You've seen the patient, you've examined them, you've clinically assessed them, review the imaging, and then check back to see what was a report from the radiologist, just to familiarize yourself with imaging. And that allows you to then feel more confident when you go back to look at imaging of another patient. Moving on now to large bowel obstruction. So the most common causes of large bowel obstruction are colorectal carcinoma and diverticular strictures, and less common causes include hernias and volvulus. So this is what cecal volvulus looks like. It's often described as a fetal appearance. And this is sigmoid volvulus, classic MCQ question, coffee bean appearance, barn door sigmoid volvulus, that is. This is Wriggler's sign. So in healthy individuals, only the inner wall of the bowel should be visible on an abdominal X-ray. And if there is free air in the abdomen, for example, pneumoperitoneum, both sides of the bowel will actually end up becoming visible, and that's what's known as Wriggler's sign. Causes of this include perforated abdominal viscera or any recent abdominal surgery the patient may have had. And basically, you really want to be looking for free air under the diaphragm using an erect chest X-ray if you're suspecting pneumoperitoneum. And that would look something like this. So as you can see here, there is air under the hemidiaphragm, and that's what we refer to as pneumoperitoneum. Sometimes people get confused with the gas bubble under the left hemidiaphragm, and that's the stomach. But if you can appreciate here at the inferior aspect of this plain film, that's the stomach gastric bubble, and this is pneumoperitoneum because it's directly under the diaphragm. So again, going back to our acronym, we've covered the bowel and other organs. We've looked at the difference between small and large bowel, but again, we've got other organs here to consider. So although X-ray and abdominal X-ray is definitely not the modality of choice for these organs, but we can sometimes appreciate things like the liver, kidney, psoas muscles, stomach, and the spleen. And the stomach can often contain a varying amount of gas. So once you've looked at other organs, you can then move on to bones. And as I said earlier, surprisingly, lots of bones are actually visible on the abdominal X-ray, which is not only helpful in identifying bony pathology, but also acts as very useful landmarks to estimate roughly where soft tissue structures are. So one I kind of like to remember is that at the level of the ischial spine, you're expected to have your vesico-ureteric junction. So from looking at this radiograph, you've got good appreciation for ribs, lumbar vertebra, sacrum, coccyx, sacroiliac joint, and your proximal femur. And that allows both clinicians and radiologists to comment on a wide range of bony pathologies, including fractures, osteoarthritis, Paget's disease, and bony mets. So just looking at this radiograph at the moment, I think there are two main findings that I want to talk about. One is, if you can see, there are multiple focal sclerotic lesions within the bone. And this patient has a history of breast CA. So this is essentially showing bony mets. And in terms of foreign bodies, you can see here, this patient has an IUD in situ. So again, something that would definitely be written on the report, but very useful if you're the clinician that's on the ward reviewing the patient, just to acknowledge the fact that you have seen that there's an IUD in place. Again, similar picture here showing sclerotic mets in a patient with prostate cancer, and the sclerotic lesions are marked with white arrows. Last but not least, we need to review any calcification or other artifacts. So that's the C in our acronym. Here we've got an example of a left-sided renal staghorn calculus. So again, very characteristic appearance there. And here we've got an example of a belly button piercing. Again, it might seem obvious now, but when you're initially looking at the film, you might not be sure what that is, but very easy appearance. So you shouldn't forget what that looks like. So just to close then, some key take-home messages. My main piece of advice for all of you would be to make sure you've got an approach to looking at plain films, particularly when you're starting as a junior doctor. I think if you get into a system of trying to make an attempt to review some of the images yourself, it will put you in a better position. So remember the ABCS acronym that we looked at with musculoskeletal plain films, and the BBC for abdominal X-rays. I'm also going to stress the importance of having multiple views. You don't fully gain an appreciation for what a lesion or a fracture will look like unless you've seen it in multiple views. Again, it's really important to review previous imaging, even if it's not the same modality. So for example, X-ray to X-ray. If it's X-ray, but there's a previous CT, it's really helpful to read the report and try and look at the images to see how have things changed since the previous scans the patient has had. And maybe because I'm a bit biased because I'm a radiologist, but I think about what modality of imaging is most appropriate. As juniors, you're often put in a difficult situation where your consultant said, please, can you book this patient for a CT scan for XYZ pathology? But if you're not sure about the exact reason, it's often helpful to discuss with radiology. You can pick up the phone and call them and say, look, this is the clinical question that I would like answered. Please, could you guide me on what the most appropriate imaging modality is? It may be the case that they'll recommend something different, and that's purely from the point of view of that a different imaging modality may be better in viewing what clinical question you need answered, and it may be in the best interest for the patient. So this is the feedback form QR code. I'm going to come back to that in a short while. Do we have time to do some cases or questions?
Yeah, definitely we do.
We do. Okay, all right. I'll run through some cases with you now. I think if the best way is if you guys write comments on the chat, and then we'll just discuss through things from there. I hope some of these images project well. If they don't worry, I'll just talk you through them afterwards. So this is our first case. If you guys just put on the chat what you think of the images.
Someone said fracture of the third metacarpal. Oh, quite a few people saying that.
Yep, good spot. So yeah, that's a third metacarpal shaft fracture of the left hand. So just going back to this image then, again, it's really important to concentrate on what side it is, what bone is fractured, and whereabouts in the bone. So we know that this is a left hand. We can see it's a third metacarpal that's gone, and it's bang in the middle. So it's the shaft of the metacarpal. And what do we think of this one?
Someone put dislocation at PIP, fifth metacarpal.
Yep.
People are
so
saying
that's exactly correct. So there's a fifth finger proximal interphalangeal joint dislocation. And there's also something called a volar plate fracture. So with the eye of faith, I don't know if you can see my cursor, but there's a small bony fragment here. And that's a small little flake that's come off, which shows that there's a fracture. Again, I'm just ramming the point home a bit, but just to emphasize that we really do need multiple views, because this would have been missed otherwise on if we only had a single view. But good spot. And what do we think of this one? We're going to abdo X-ray now.
foreign body.
Yeah.
Foreign
So there's a nice nail there. So yeah, foreign body. So again, it may not necessarily be a plain film looking at organ pathology. It can also be to look at foreign bodies as well. So yeah, that's correct. Abdominal foreign body.
People are saying clavicle dislocation, misalignment of the clavicle, AC dislocation.
Yep, so very similar to one of the cases we saw earlier. So again, remember, we're looking for the 8mm rule there. So that's definitely wider than 8mm. And again, just tracing that inferior cortex of your acromion all the way across. And it should really be in line with the clavicle. And here there's definitely a step. So we know that our acromioclavicular joint is not intact. So well done. And this one.
Someone did ask for the last image, what were the white things near the heart?
Let me go back. Oh, so that's clips on clothing. So again, very good spot. But it shows that you've got your eye in on the images, and that would not be classed as a foreign body in the abdomen or in the thorax. It's external, it's on the patient's clothes.
People are saying NOF for this one.
Yep. And if we think about the classification system I showed you guys earlier on that schematic diagram, does anybody know what kind of fracture this is? Like if we were to be more specific than neck of femur.
Someone said extracapsular fracture, base cervical fracture, subcapital.
Yep, so extracapsular is correct. So this is intertrochanteric. So if you just trace this lucent line, you can see it's definitely going in between the greater and lesser trochanter. So this is the extracapsular intertrochanteric fracture. And this one?
Someone said fractured head of radius.
Yep, that's correct. And does anybody know what is the other sign that we can see on the X-ray?
Anterior sail sign. A lot of
Yeah,
people.
you guys are nailing it. So with the eye of faith, I don't know how well you can see it, but there's a darker gray area here, which represents your anterior fat pad. You can obviously see that's raised, and that's because there's a radial head fracture. So that is correct. So that is everything. Unfortunately, I do have to leave now. I don't know how we're able to do Q&A. Are you able to email me with questions and I can get back to you, or?
Yeah, we have about 5 or 6 questions. So I can email those forward to you and then maybe post a reply on our social media.
Yeah, that would be great.
Okay.
Okay, thank you very much.
Thank you, everyone.